Bismillahirrahmanirrahim. I'm Dr. Muhammad Ibrahim Hassan, Assistant Professor of Bariatric and Laparoscopic Surgery at Shams University. My talk today will be about the metabolic and bariatric surgery for children and adolescents. This topic is a very hot topic and carry a lot of debate whether to take children or adolescents for surgery or not. This carry a lot of controversy, so I come today to get focus on these points to be clear for our colleagues. As all we know that the overall rate of childhood obesity have been tripled since 1980. The prevalence of obesity in adolescents increased about 4 times since then. In 2013, the obesity was recognized by the American Medical Association as a disease, and this is a big point and a time for change to look for the obesity not only like a figure or a shape for a child or adolescent or something that carry psychological element, but it also known as a disease that's accompanied by many diseases, and this opened the door to increase the research in this field. As all we know that the obese children and adolescents are more likely than normal weight to peers to suffer from different diseases like endocrinal diseases, cardiovascular disease like hypertension, cardiac problems, pulmonary disease, and mainly the obstructive sleep apnea, pulmonary diseases, orthopedic diseases. This is because the weight for child can may lead to the genovalgum or genovara and many orthopedic problems, and the child may fall and will need surgery and fixation, and this is not suitable for an obese child or obese adolescent, in addition to other psychological and other problems. Skinner and Skelton expanded the definition of severe obesity to include class 1, class 2, class 3 obesity using the following the American Heart Association criteria. As we know that the underweight, this is a patient who are less than 5 percentile. However, then we consider the obesity class 1 to be more than 95th percentile to less than 120% of the 95th percentile. Obesity class 2, this is between 120% to 140 of the 95th percentile. Also, the obesity class 3, this is more than 140% of the 95th percentile, or the body mass index more than 40 kilogram per meter square. Also, we know that the body mass index could be assessed using the equation or the ratio between the weight over height square, and this is ratio is mainly used for the adult classification for obesity. However, down in children and adolescents, we can use the 95th percentile ratio. What about the treatment option for children and adolescents? We can see that maybe changes in the dietary behavior, physical activity, and pharmacotherapy, and my topic, which is about the bariatric surgery. Changes in the dietary behavior, I think that my colleagues in this conference have talked about this in more details, so I will not focus on this in my presentation. In addition to the physical activity behavior, I will give some points mainly about the pharmacotherapy and bariatric surgery. Usually there is also been a major shift of thinking about the use of medications, nutrition and behavioral training, physical therapy, and metabolic bariatric surgery together instead of separately. So we are not thinking about just only to have pharmacotherapy alone or behavioral therapy alone. No, should be a multidisciplinary team for talking about the how to manage the childhood obesity or the adolescent obesity. While timing of each of these interventions remain unclear, for the patient suffering from severe obesity disease, most will require all of these therapies to attain a healthy weight and completely control the weight control comorbidity. As I talked before, that when we are talking about the obesity, we are talking not only for shape or not figure or psychology of the child or the adolescent, we are talking about the comorbidities that accompany with obesity. What about the pharmaceuticals? There is a big controversy about what drugs to be used for management of obesity. I think usually I recommend for the patient dietary style or behavioral therapy and exercise. I don't like or I don't recommend the use of any pharmacotherapy. This is because, in my point of view, I think that the use of medication have a greater risk. This is because most of these medication of unknown sources and ingredients that no confirmed mode of action to decrease the weight. I think that for any drugs down to give weight loss, this depend on one of two ways. The first way, it can act as to increase the metabolic activity inside the body, and so it will contain L-thyroxine in its ingredient. Even if the drugs ingredients don't contain L-thyroxine, mostly it will take part of this. And so if there is a weight loss that will be achieved, it will be accompanied by marked complications like hypertension, tachycardia, irritability, hot intolerance, all the symptoms of hyperthyroidism. Or it can act central. The drugs may act central, so bypassing the blood-brain barrier to act on the satiety center. And if this occurs, so it will carry many complications, because if a drug that can pass through the blood-brain barrier to act on a special center for satiety center, sure, it will affect the nearby centers in the brain. So I saw many patients that have used the different drugs, and now they are complaining of seizures or irritabilities, convulsions. That's why I don't recommend using pharmacotherapy. And despite the relatively low efficacy of orlistat in comparison to other weight loss medication, it is the only drug that currently approved by the FDA for the treatment of obesity in children and adolescents. This is because the orlistat, I think, this is the most safe. But all we know that its effect is mainly about the meal, the fatty meal that the child or the adolescent will eat. So I can take orlistat to decrease the fat absorption from the next meal, and not to decrease the actual weight, the already obese child for weight loss. Now I'm talking about my topic mainly, which is about the metabolic and bariatric surgery. Usually the concern about the bariatric surgery for children and adolescents include many questions. This is a question marks about taking child for surgery or adolescent for weight loss. The most important thing in bariatric surgery is to make a balance between the advantage of the surgery and the risk of the surgery in one hand, and the complications and the comorbidities related to the obesity. So there have to be a balance when we are thinking about bariatric surgery. So I repeat the same thing, that when we are dealing with obesity, we are not dealing about the figure or psychology, we are dealing with the comorbidities that related to that disease. So we should think about it seriously and put surgery in consideration. So there are many concerns about the bariatric surgery for children and adolescents, which is these questions include whether to obtain an informed consent from minor. Is it acceptable to take the consent from the minors? I'll talk about this. What about the timing of intervention? Whether to take that, is it I can ask the patient or his family to go to surgery, whether at what age, whether it is 8, 10, 11, 15. So this is great concern about this, whether or not surgery is cost effective, whether it is cost effective or not, maintenance of weight loss, whether this will be the final surgery, or the child or the adolescent will gain weight again at older age, and so he will need another surgery. What about to ensure the healthy growth through adulthood, or this surgery will cause nutritional deficiency, so it will affect the health of the adolescent or not? And what about the compliance of the post-operative nutrition diet after this? Now, what about the metabolic surgery should be considered mainly for the patients? What about the children who have obesity? How can I select the children that have obesity and they are candidate for a bariatric surgery? Usually, this is passed through many stages. Started from 2004 in Gital. Said that we are talking about the body mass index to be more than 50. to be more than 40 without any comorbidities, or with comorbidities like diabetes mellitus, hypertension, or obstructive sleep apnea, to be more than 40 with these comorbidities, or to be more than 50 without any comorbidities. This is Inge et al. At about 2004. Pat et al. At 2009 say that it will be more flexible to be the body mass index more than 35 to be with one of the comorbidities like hypertension, diabetes mellitus, obstructive sleep apnea, orthopedic problems, or body mass index more than 40 without any comorbidities. So he will be a candidate for surgery. In 2018, the American Society of Bariatric Surgery gave us the rules and the inclusion criteria for any adolescent or children to be included or to be candidate for bariatric surgery. Here's down for the last recommendation for the American Society of Bariatric Surgery. Said that the body mass index to be more than 120% of the 95th percentile with one of the comorbidities like hyperlipidemia, hypertension, type 2 diabetes, insulin resistance, steatohepatitis, orthopedic disease, or the body mass index more than 140% of the 95th percentile without any comorbidities. So we are answering the question which what about the children who is candidate for bariatric surgery? This who follow this BMI to be more than 120% of the 95th percentile with one of the comorbidities, or to be more than 140 of the 95th percentile without any comorbidities. What about the comorbidities that should be considered in adolescent, especially the psychological burden of the obesity? This is a very important point. We are talking not only about the orthopedic, cardiac problems or diabetes, we are talking about the psychological problem. I face many adolescents and children who cannot go to his school or start his normal life. This is because of the obesity. So I can put this in mind to be one of these comorbidities. And the cardiac risk factors, given the poor outcome of the medical therapy, this is very important to point that there is a poor outcome of the medications, and behavioral arrangement is very difficult for the child, so we can consider for a bariatric surgery. What about answering whether it is acceptable to have a consent from minors or not? We see that the adolescent less than 18 years require consent by the parents or the guardian and assisted by the adolescent whenever possible. So we are not taking the consent from the child alone or the adolescent alone. Should we consult his family and take a consent from his family? Both the parents and adolescent must be informed about the risk and benefits of the surgery and the long-term outcome. This is a very important thing, that to talk to the different complete explanation of our surgery for and clarification of the different techniques, different risk factors. What about the different complications that may occur by each percentage? Even the complications that occur about 1% should be informed to the patient to explain to them what is the advantage and disadvantage. And as I told before, they are using the balance between the advantage and disadvantage, and this is to consult not only the child or the adolescent, also his parents or the caregivers. Adolescents with severe obesity are at increased risk for the adult obesity with increasing with age and the weight. This is very important. That is child that having now he is obese at the age of 8 or 10. Mostly he will have obesity at the age of 20 or 30, and so carry risk for different comorbidities like hypertension, cardiac disease. He may need cardiac catheterization, PCI. He may need further interventions. That's why all over the world they are considering of taking the bariatric surgery to be covered by the insurance. This is because they found that anyone at the age of 15 or 20, he will be morbidly obese at the age of 30. He will take medications for cardiac problems, for chest problems. He may go for orthopedic surgery, and this is in the point of cost effectiveness will need a lot of money, and so these patients will stay at home. And so When staying at home, he will not work, and so this give a burden down for his country, and so it's an easier and it's for cost effectiveness to take this patient for a bariatric surgery is most beneficial rather than to keep him just on medications. Metabolic bariatric surgery is the most effective and durable treatment for severe obesity in the adult and adolescent. However, the lifestyle modification, exercise, and medication may be necessary to maintain the long-term outcome. And so, when we are talking about the bariatric surgery, I don't I'm not operate the patient and then leave him alone. No, this is a long-term journey between the bariatric surgeon and his team with the patient after surgery. There should be a multidisciplinary approach. We're talking about the patient, including the psychologist, including the nutrition consultant, including the bariatric surgery to follow up the operation, and so on. Developmental delay and autism spectrum or syndromic obesity. Following the recommendations in 2004 and 2009 and 2013, this will be excluded from bariatric surgery. No, now the recent recommendation from the American Society of the Bariatric Surgery, this is the recommendations that all or most of the bariatric surgeons follow in their career, their work. Developmental delay, even the autism spectrum or even the syndromic obesity shouldn't be a contraindication for metabolic bariatric surgery, but they need a special approach. Each patient and the caregiver team will need to be assessed for the ability to make the dietary and lifestyle change required for surgery. I usually say that the bariatric surgery is not a difficult surgery. This is they need special training. However, the most important not to operate that surgery. The most important is how to select the patient, and when you are selecting the patient, I'm asking about the compliance of the patient. I'm not doing just the surgery and leave the patient. I'm sure I want to be sure that the patient will follow the different diet styles, different recommendations. He will be away from the contraindications of surgery. This is the most important, that the surgeon can select the patients that can follow the post-operative plan after this. Another contraindication in the last 10 years now become not contraindication. Now they found that unstable family environments, eating disorders, mental illness, or even prior trauma shouldn't be considered a contraindication for metabolic bariatric surgery. But as I said before, that the most important here is to select the patient. Found that if the adolescent or child should be with his family, they understand the plan after surgery, or a caregiver after this, and not when you are talking about the unstable family environment. This doesn't mean that I select the patient with unstable family environment and leave him. No, I should be sure that the patient have a special caregiver that can help him to follow our post-operative plan. The complication and risk of obesity usually outweigh the complication and risk of the metabolic bariatric surgery in adolescents. Again, usually we are using the balance between asking what about the surgery, its complication, its risk in one hand, and on the other hand, what about the obesity and its comorbidity on the other hand. So at every stage in our assessment, we should look for the balance about this. Lifelong vitamin level monitoring and supplemental vitamins are necessary after any metabolic and bariatric surgery. It is very important that to keep the patient with special nutritional support after surgery. So it is not acceptable at all to do surgery for the patient that carries a risk of some element of hypovitaminosis, and I know that the patient will not take his vitamins, and so this will lead to serious complications. So it's not acceptable at all. So it's lifelong vitamin level monitoring and supplemental vitamins are necessary after any metabolic and bariatric surgery. Long term, there may be a need for further surgery or procedure after metabolic surgery. What about the weight gain after surgery? This will be differ from one surgery to another that I will take later after in my presentation. And now I will take more details about what are the types of the metabolic and bariatric surgery. Usually then we have certain classification of our surgery to include restrictive surgery, malabsorptive surgery, and combined surgery. When I'm talking about the restrictive surgery, this means that there is a restriction for the food intake. Usually then we have the stomach that carries about 3 to 4 liters of food and fluids, and then the food or the fluids pass through the pylorus, which is the junction between the stomach and the small intestine, and then the food pass from the stomach to the small intestines, which in average down we have about 8 meters of small intestine where the food will be absorbed. So our surgery usually between whether it will be restrictive or malabsorptive restrictive, we are not operating at all at the small intestine. Our concern is mainly the stomach. This is the most important in restrictive surgery. Restrictive surgery usually lead to the decrease the food intake without any affection of absorption at all. And we have different kinds of restrictive surgeries like vertical band gastroplasty, adjustable gastric band, and the most widely spread surgery, which is the sleeve gastrectomy. This is the restrictive surgery. What about the malabsorptive surgery? This is not acting at all at the stomach. We are concerned here is the small intestine and its absorption of food, and we have different operations like jejunal bypass, biliopancreatic diversion, and combined surgeries that carry the 2 points, which is the carry 2 actions, decrease the food intake and also decrease the absorption of the food after this, like the gastric bypass surgery. As you see, this is a figure of sleeve gastrectomy. First of all, we should know the anatomy of the stomach. Stomach is containing the fundus, the body, and the antrum, and then the pylorus through which the food passes to the small intestine. As we see that the fundus of the stomach contain the center for the hunger hormone, which is the ghrelin hormone. So the idea of sleeve gastrectomy here, which is the most widely used operation for adolescents and the children, this is a restrictive procedure, not a malabsorptive at all. There is no action at all at the small bowel, only through the stomach. Its idea here is to remove or excision for about 80% of the stomach, completely excised from the body, and so to keep a long tube-like pouch or long tube-like stomach with the removal of the fundus of the stomach, which is the center for the ghrelin hormone. So after follow-up of our patient after sleeve gastrectomy, we found that there is marked decrease of the ghrelin hormone. This indicates that the removal of such part, mainly the fundus of the stomach, give good results at long term. How it acts for the patients? So usually when the patient after sleeve gastrectomy, he starts to decrease his food intake, and also he will not feel that he is at hunger except for at longer intervals. So it decreases the hunger sensation for the patient, and when he eat, he only little amounts is because the stomach is already become very small gastric pouch. This is the most important operation here to show you for the surgery after this. Here are the types of the surgical techniques that should be tube-like gastric tube with the complete excision of the fundus of the stomach to remove the center for ghrelin hormone, and this is the most important to do uniform stapling. When I talk about uniform stapling, this is a figure showing down the intraoperative figure during surgery. Here we are doing entering some nasogastric tube known as a bougie tube down. After this, we are tailoring the gastric pouch along the gastric tube, which should be uniform stapling. This stapler use stapling and excision of the stomach. Should be no twist at during surgery, so there will be obstruction and repeat attacks of vomiting after this. This is another figure showing down the intraoperative our intraoperative technique during surgery, during down. So it's very important here to completely remove the fundus of the stomach. If the fundus will be retained after surgery, this is having the high liability to distend and expand after this. Usually down there is a question mark about the sleeve gastrectomy, whether after sleeve gastrectomy, whether the patient will increase weight or not, whether the stomach will be expanded after this or not. I think that thanks God for that the stomach has a sense of distensibility. This is because during Ramadan we are fasting. After this we can eat a lot of food. This is because there is element of distensibility of the stomach. However, the excision or longitudinal stippling, tube-like stippling, carrying the lowest percentage for expansion after this. So it's very important here to completely remove the fundus of the stomach, and this give good long-term results and persistent weight loss after surgery, after removal the fundus of the stomach. This is another figure showing that there is a uniform stippling of the stomach. There is no twist, there is no obstruction, just tube-like, completely tube-like, and this is uniform without any twist or obstruction. Vertical sleeve gastrectomy or sleeve gastrectomy has become the most used and the most recommended operation in adolescents with severe obesity for several reasons. Why we recommend sleeve gastrectomy? This is because they have near equivalent weight loss is compared to the Roux-en-Y gastric bypass in adolescents. Usually then we are talking about whether to do the patient sleeve gastrectomy as a restrictive procedure or doing the patient Roux-en-Y gastric bypass or mini gastric bypass as a combined malabsorptive and restrictive surgery. Usually they are thinking about this, what is the most beneficial for the patient, whether need more compliance, less follow-up. This is very difficult to control child, so usually don't take the sleeve gastrectomy taking the upper hand. It has fewer reoperations after this, better iron absorption is compared to the Roux-en-Y gastric bypass, near equivalent effect on the comorbidities as Roux-en-Y gastric bypass and adolescent. We now have many researches about the effect of both sleeve gastrectomy and Roux-en-Y gastric bypass. We found that the sleeve gastrectomy have equivalent effect on the other comorbidities, and so is why we are doing more complex procedure like Roux-en-Y gastric bypass, and we have the sleeve gastrectomy that can give the same results with fewer complications. And finally, long-term outcomes of GERD after sleeve gastrectomy are still not well understood. Usually, sleeve gastrectomy may carry a risk of gastroesophageal reflux disease after this, and many research talk about there is a percentage of reflux esophagitis, but this is usually under research and not confirmed till now. This figure showing the gastric bypass or mini gastric bypass, as we see that they have down stomachs that carry about 3 to 4 liters of food and fluids, and then the food will pass along the small intestine, which on average all the humans have an average about 8 meters. So in our surgery, in gastric bypass surgery, we are doing our surgery in 2 stages. The first stage along the stomach. The second stage will be along the small intestine. We are doing stippling and long tube-like pouch, as we see on the figure on the right side. This is long tube-like gastric pouch. So this ensures the limitation of the food intake for the patient, and the food will not be passed along its normal pathway through the 8 meters of small bowel. No, after just 2 meters from the start of the small bowel, there will be anastomosis or connection between the newly formed gastric pouch to the small intestine, and so there will be less absorption. Before the operation, the patient can eat about 3 to 4 liters of fluids and food, and then pass along the small bowel to be absorbed along 8 meters of small intestine. After surgery, there is just long tube of the gastric pouch, so to ensure limitation of the feeding, and also the food will be absorbed only along the 6 meters. This is because 2 meters of the small bowel have been excluded, not from the body, just they are excluded from the way of the food and not from the body. In gastric bypass surgery, there is no parts from the stomach or the intestine will be removed from the body. All will be retained in the body, but there is modification in the way through which the food pass along the stomach and then the small bowel. So gastric bypass surgery is the gold standard for the surgery, mainly for the adult operation. This is the first point. Second point, it is combined surgery, including restrictive part and malabsorptive part, and this is very important for weight loss. Finally, this include a malabsorptive part through which exclusion of about 2 meters from the way of the food, and only the food will pass along 6 meters, not 8 meters, as the normal pathway. These 2 meters of small bowels that have been excluded for during surgery is very important for weight loss. This is the most important. And second, for the persistence of the weight loss after this. However, it's very important for absorption of some minerals and vitamins like calcium and iron. So it's very important to tell the patient that if you are doing a gastric bypass, we have a percentage for hypocalcemia and they have anemia, so the patient will keep on iron supplements and calcium supplements. That's why we are not preferring for doing gastric bypass for children and adolescents. This is because it carry a higher complication as compared to the sleeve gastrectomy, which is sleeve gastrectomy just will take some vitamins and fewer iron malabsorption, and so it is preferred to do sleeve rather than the gastric bypass surgery. This is what I talk about the advantage and disadvantage. What about the nutritional risk? That the many metabolic bariatric surgery create a potential for both the macro and micronutrient deficiency, reduce the food volume, which is a feature of all the procedure, may result in adequate protein intake. The Roux-en-Y gastric bypass may sometimes limit the fat absorption as a consequence result of long-term hypovitaminosis of vitamin A with D and K. Iron deficiency and low vitamin D level are more common in the patients with the disease of the obesity, particularly in females. Anemia is common after metabolic bariatric surgery and may relate to low level of iron. So we can see that there is some nutritional deficiencies after surgery. However, we are talking about there is a balance between the obesity and comorbidities, and also on one hand, and the surgery and its related issues like hypovitaminosis or something like this that could be supplied as supplements and so give better results. Is there any solutions or any options for childhood or child or adolescent obesity rather than surgery? So, there is emerging treatment like for endoscopic bariatric therapies have recently been approved by the FDA. As we see that in this figure, this is the endoscopic balloon. Endoscopic balloon is one of the solutions for the risk patients for the childhood or adolescent obesity. As we see, this is its idea depend on that we are put space occupying pole or a balloon inside the stomach, so it makes space occupation, and so when the children or adolescents start to eat, he will feel that he will be completely full at an earlier stage rather than complete meal. Okay, this is just it takes part of from the stomach to be involved by the balloon. What is the advantage and disadvantage of the balloon? When I think about the advantage, this is not a surgery at all. This is just an endoscopic procedure, not under general anesthesia, just taking hypnotic drugs. Usually the patient come before the procedure by just for 10 minutes before the procedure. The procedure take about 10 minutes and then the patient turn to his home just after 30 minutes to his home, will be back to his home. So it is an easy operation, completely safe. What about the disadvantage of the endoscopic balloon? Found that the endoscopic balloon carry two main disadvantages. The first is that it is a temporary procedure, just only for 6 to 8 months. After this, you should remove the endoscopic balloon. Second is this need a high compliance from the patient. Usually don't recommend the endoscopic balloon for the patients who want to follow a dietary style and dietary modification and need some treasure or some assistance. You can use endoscopic balloon. But if any patient, we can see that to assess the patient is that he is not suitable for any dietary behavior. So it's not recommended to use the balloon. This because we are insert a balloon for the patient. We usually don't depend that 50% depend on the balloon and 50% depend on the patient to follow a special dietary style and dietary plans to follow to achieve the better results. This is not followed in our bariatric surgery like sleeve gastrectomy and gastric bypass. In our surgery, we usually don't depend on the surgery for about 90% and only 10% left for the patient. And if the patient show no compliance at all, so it will not be away from our plan for weight loss. But in endoscopic balloon, 50% depend on the balloon and 50% will depend on the patient himself. So we can find that the weight loss after endoscopic balloon is variable. It means the patient may lose about 50 kilograms or he may lose just only for 10 kilograms. Why? There is a great discrepancy between the weight loss between these two patients. This one patient follow dietary programs or the dietary plan combined with the balloon and the other does not follow it. That's why it's very important to select the patient for the endoscopic balloon. Usually these devices share the following common characteristics like they are adjustable, they are reversible, they should only be used in the setting of multidisciplinary pediatric team. As I said, just not to insert the balloon and leave the patient. There should be psychological support, should be nutritional support and follow up by our team. The effect in terms of the weight loss is less than that of the metabolic bariatric surgery. As I told before that this depends mainly on the patients and not only for the operation. There may be a rule for the use of alternative therapies when the metabolic bariatric procedure must be delayed due to other health condition or is not indicated. If the patient is selected for a bariatric surgery, however, we have other comorbidities like cardiac problems or respiratory problem, we can use the endoscopic procedures as a first step before surgery just to achieve marked weight loss before surgery. As with adults, these therapies should be used for the weight management in those who find the metabolic bariatric surgery unacceptable or inaccessible, or as adjunct therapy for the preoperative weight loss. When I'm talking about the conclusion, I want to first of all to answer the questions that I started by during the early in the presentation. What about what patients that candidate for surgery? Those are the patients that are more than 120 percentile with comorbidities, or that more than 140 without any comorbidities. What about the age of the patient that candidate for surgery? I think that our recommendations or our guidelines say that in 213 was from age of 13 or 14. Now the last recommendation from the American Society of the Bariatric Surgery, we can do our surgery for at the age of 10. What about the cost effectiveness? It's highly cost effectiveness is compared between the drugs and different comorbidities that may occur for the child at a long term. No, it's cost effective to do the operation. What about the nutritional support? We should select the patient with his caregivers and his family to follow up with all the our plan, post-operative plan. That the metabolic bariatric surgery, as we see, is clearly one of the main obesity treatment modalities with the best sustained weight loss and the control of the obesity-related comorbidities. Data support the use of metabolic bariatric surgery with the severe obesity, either vertical sleeve gastrectomy or gastric bypass for the adolescent with BMI more than 35 or more than 120, or BMI more than 40 or more than 140% of the 95th percentile. Vitamin level should be, this very important point, should be monitored before and after the metabolic bariatric surgery with all attempts to maximize the adherence with the vitamin supplements long term. Prior weight loss attempts, tenor stage and bone age shouldn't be a barrier to the definitive treatment. When you are selecting the patient for a bariatric surgery, we leave him a chance to follow dietary modification for at least 6 to 8 months before serious attempts for dietary plans before taking the patient to the operation or recommend a bariatric surgery for him. Multidisciplinary team should stabilize and treat any pre-existing disorder, assure the stable social support, assess and assist with the nutrition and activity knowledge, and consider the addition of medication. Thank you.